Welcome to Grace 3, Acute Dizziness and Vertigo in the Emergency Department. Acute dizziness or vertigo accounts for 2.1% to 3.6% of ED visits annually, costing approximately $10 billion in the U.S., largely due to imaging. Prepared by Dr. I. Habash. Let's explore the evolution of diagnostic approaches. The traditional method, developed 50 years ago, relies on symptom reports. Modern evidence suggests focusing on timing and triggers. Grace 3 guidelines provide evidence-based recommendations for acute dizziness and vertigo care. We identify 3 patterns of acute dizziness: acute vestibular syndrome, AVS, spontaneous episodic vestibular syndrome, SEVS, and triggered episodic vestibular syndrome, TEVS. These patterns guide diagnosis and testing, with Grace 3 assessing evidence for acute dizziness under 2 weeks. Grace 3 addresses key PICO questions. Should AVS patients undergo neuroimaging? How should SEVS and TEVS be diagnosed? What are the treatments for vestibular neuritis and BPPV? These questions guide evidence-based care in the ED. The Grace 3 recommendations focus on an evidence-based approach with 15 recommendations, clinician training, and diagnostic pathways. These ensure specific approaches for each syndrome, enhancing the diagnosis and treatment of acute dizziness. For diagnosing acute vestibular syndrome, AVS, use HINTS testing to distinguish central from peripheral causes. Hearing and gait assessments are crucial. Avoid routine imaging unless necessary, ensuring accurate diagnosis with high certainty of evidence. In diagnosing spontaneous episodic vestibular syndrome, SEVS, emphasize clinical examination. Avoid routine CT scans, but use vascular imaging if TIA is suspected. This approach ensures accurate differentiation between central and peripheral causes. For triggered episodic vestibular syndrome, TEVS, use the Dix-Hallpike test for BPPV diagnosis. Avoid routine CT and MRI unless necessary. This method ensures effective diagnosis with moderate certainty of evidence. Treating vestibular neuritis involves shared decision-making for steroid use within 3 days of symptoms. Discuss potential benefits and risks with patients, and inform them about the recovery process, regardless of treatment choice. For benign paroxysmal positional vertigo, BPPV, confirm diagnosis with the Dix-Hallpike test and perform the Epley maneuver. This treatment is strongly supported by evidence, ensuring effective management in the emergency department.